Greetings, everybody. Welcome to our LHS Collaboratory session today. I'm Chuck Friedman. I'm one of the co-chairs of the Learning Health System Collaboratory. It's my pleasure to be hosting this session today. And I need to begin with some general words of introduction about this session. First of all, the session is being recorded and the link will be shared with all attendees and registrants. The session will also be closed caption. We would very much like to have this session be interactive, as I'll describe in just a couple of moments. And do you want to go back to the previous slide, Lisa, please? As I'll describe in a couple of moments, you can post your questions in the Q&A feature on Zoom throughout the session. The chat feature will not be available to you given the way that we have set this session up. Next slide, please. So our plan for today is a session that will be in 3 parts. Our featured speaker, and we're delighted to have her with us, is Professor Rachel Richesson. Recently joined the faculty of the University of Michigan Medical School in the Department of Learning Health Sciences. Following her presentation, which will of course focus about standards and their role in learning health systems, a topic of great interest to many of us. Following her presentation, we will have an abbreviated question and answer session, and we will try to get to as many of your questions as we can. 4 questions have already come in response to the request for some questions in advance. We'll certainly get to those during this abbreviated Q&A session. And then in the third part of the session, which will take the final 30 minutes, we're hoping that many of you will stay around. At that point, we will unmute everyone who is present, and we hope most of you will be for a fully interactive session around the topics that Rachel has presented in her in her talk. So next slide, please. So now let me introduce very briefly Dr. Rachel Richesson. Rachel, as I said, is a professor in the Department of Learning Health Sciences in the medical school here. We were extremely fortunate to be able to recruit Rachel from Duke University, where she had been for the past, I believe, 6 years. Prior to that, she was a faculty member at the University of South Florida. She holds a PhD and a master's in health informatics and a master of public health, all from the University of Texas. She conducts original research on the quality and usability of data from electronic health records for research and has fostered numerous interdisciplinary research collaborations. She's directed implementation of data standards for a number of multi-site clinical research and epidemiological studies, including the NIH Rare Diseases Network, Type 1 Diabetes TrialNet, the Environmental Determinants of Diabetes in the Young, and the National Distributed PCORI Network. So Rachel will add further aspects of her background as she deems appropriate. I do want to mention in closing, and before turning the podium, the virtual podium, over to her, that she also serves as co-chair of the emerging national movement to mobilize computable biomedical knowledge, which is based here at the University of Michigan. So Rachel, it is truly a pleasure to have you with us, and we are all greatly looking forward to your presentation.
Thank you so much for that introduction and for having me here. I just want to make sure, am I sharing my screen?
Yes.
Everyone's seeing it. Okay, perfect. Terrific. Well, I'm just thrilled to be here and be part of the department and talking about data standards today and opportunities that I see for for learning health systems. So I'll talk a little bit about my thoughts on how these two fit together. Then I'm going to highlight some challenges, just very broadly, of data standards and why they've really eluded us thus far and have proven to be so difficult. But then I'll also end with some opportunities, and one of which, as you mentioned, is this standards consult service. And then I hope we have discussion as a group. And then for that last half hour, I thought we'd pilot this standards consult service and see if we can have some discussion about very particular questions and problems, and just see where our collective heads sort of come at that, and what my perspective might bring to some of those issues that you have. So I encourage you to think of those kinds of real world questions and real world problems that you're dealing with, and definitely please in multiple discussion sections, bring up your questions or comments. So when I first started at the Rare Disease Clinical Research Network, I was lucky enough to read this wonderful article that came out in the New Yorker about really data-driven healthcare. And so this article was the story of the Cystic Fibrosis Foundation patient registry, and how that registry originally was used to evaluate and benchmark different clinical centers for cystic fibrosis, and look at the outcomes of those patients and see what they could do to improve it. So the registry was really born out of the question of, how can we look at what patients are doing better at which places and why? So what they found was really sort of contrary to what the common thought was at the time, which was that, hey, all our centers are pretty good. We're doing roughly the same things. The outcomes should be similar. But what they found was some centers that were performed less well than others in terms of patient outcomes, and then some that performed incredibly well. And so this gave the opportunity for this group and the physicians and healthcare teams to really look into the practices and interview the doctors and the patients and the nurses, and understand what was happening in these centers that had really good outcomes. And so, at the time, I didn't realize that cystic fibrosis would be is still the model of patient advocacy strategy and building a research strategy. So really successful patient advocacy work in terms of impacting a disease, and still is. I will say that this was the start of the Cystic Fibrosis Foundation Registry. It was started in the late 50s, and has had a number of milestones, and most importantly, has really shown how cystic fibrosis, this registry has had such an impact in terms of increasing that lifespan and the longevity of patients with cystic fibrosis, in addition to supporting a number of research efforts. And now at this point, there's well over 30 different medications for cystic fibrosis, and that was not the case when this started. But despite the tremendous research value of this registry, what's exciting to me is that this really came from not a research question immediately, like how can we find treatments for cystic fibrosis, but really just how can we understand what works best in practice and learn from it. So to me, this was really, I didn't even know the term learning health system at the time when I started this, but really quite an impressive story. And as I mentioned, really remains a model for rare diseases in terms of developing research programs and impacting patients and families affected by those diseases. So that's a very dear story to me, and really sort of what really motivated me in this space. I think the cystic fibrosis story and their registry is a really terrific example of looking at data within health systems and thinking about how that feeds into a greater ecosystem, feeds research, and then brings that back to practice. So I want to highlight this depiction of a learning health system, which really shows the idea that research influences practice and practice influences research in a learning health system. And so if you start at the bottom right, more or less, of this cycle, you'll see that we start with sort of internal and external scans. So looking at data, identifying what's going on within a system, and identifying problems for externally that are reported in the literature, as well as potential solutions. And then we move right into this design phase where we design promising interventions, and then we implement them, and we evaluate them, and we adjust, and we learn. So this model is very similar to what I know we've shared on many of these collaboratory grand rounds before, which is the data to knowledge, knowledge to performance cycle. Also, plan, do, study, act is sort of a similar model or equivalent type of model to think about how we take knowledge, implement that into practices, and then evaluate it and move on. But I think in terms of the data sources, real world data, of course, includes electronic health record systems and offers us an ability to have a more streamlined data collection than historic traditional research, which has had its entire a separate data flow, almost a silo, if you will, parallel data collection flow to stimulate research. And so we're seeing this wonderful movement now toward the use of real world data, towards the FDA accepting this and providing guidance about how to take that, understand ways to measure quality, improve quality, move it into real world evidence, which would include interventional trials. So pragmatic trials, large scale, simple trials, randomized trials, really robust designs that can give us some good quality evidence that can make us feel confident in terms of the interventions that we're designing and how well they are working in practice. And then finally, as we move to the right, the ability to disseminate that into the world, and that others then, based on these robust methods, clear, transparent data processing, data analysis steps, that future users can fully evaluate and quickly implement what we've got going. And so to me, this really is the knowledge cycle here that we've talked about, and I've heard on so many of these collaboratories and talks and things coming from our department. And I think I want to highlight this idea of knowledge turns. So all our diagrams, all our cycles have this: how do we take knowledge, put it into practice, evaluate that, improve it, and then disseminate and move the cycle forward. So to me, the big question is, what do we need to do to speed these knowledge turns? And I think there's all kinds of collaborations in terms of what to study, how to study, where to study. But I offer that data standards are one key infrastructure to really move those knowledge turns forward. And just to highlight this thought, I think most folks would not object to this idea of data standards speeding knowledge turns, but it could certainly give us a common infrastructure for both observational and interventional research, as well as a number of items. I actually forgot, I wanted to do a quick poll. And Lauren, I apologize, I forgot to do that right at the beginning, but this would be a great time to see what people think in terms of data standards. So as I'm talking about data standards can speed knowledge turns, I'd like to see the audience, if you could answer a couple of questions for me about your thoughts on data standards and how they might benefit most. So I've given you a sense of the knowledge cycle there.
The answers are beginning to come in, so.
Great. So perfect. I meant to start with this, and I got on a roll, but this is a perfect time when we can get a sense of who's on the phone and where people think the benefits are. So should we give it just another?
Yes, the numbers are still going up. 50% have currently voted. Give them a second, and I will end the poll momentarily when the numbers slow down, like popcorn.
Perfect.
Are we serving popcorn?
Note to self, I'm going to put a slide for myself that says poll right now, because I want to get a sense of who's here. So,
okay, we've got 75%. I am going to end the poll right now.
Great. I should have won both.
And I'm going to share the results so everyone can see them. Yes.
And are we seeing? There we go. Okay, so good. I almost didn't need this slide, and that was my hope. So a lot of folks agree that data standards and EHR systems, which is sort of one source of real-world data, will improve our ability to conduct research. And then I see a nice even split here, a good distribution of people that believe a standardized EHR data is sort of most beneficial towards patient care. Population health management, quality improvement, and a smaller number for research. Oh, and observational. So I would say the research comparative effectiveness and standard of care could actually be interventional or observational. So terrific. Okay, well, thank you so much, Lauren, for doing that. And I apologize that I went off script. But I think I don't have to work hard then to convince folks that that data standards really can have an impact in how we learn. in all these many activities of learning health systems, by really giving us data and eliminating the work and the transformation and the time towards understanding the data and building reports and analyses and things. We can reuse that. We could have easier study startup just in terms of data collection forms, research protocols, reports, monitoring procedures, et cetera. Data standards across EHR systems could allow us to have bigger samples with data aggregation across sites, again, with less work than and potential error with doing all these mapping and transformations that's often done. Potentially faster accrual, again, by being able to get at the data and identify diverse study populations or identify sites that have diverse patient populations and families represented, and not have to worry about these technical difficulties of integrating data that is not comparable or represented in the same standard. And finally, data standards can really help us disseminate these results, which really gets at that learning cycle of where evidence can, practice can influence research, and research can influence practice. And just to illustrate that, I wanted to throw out this notion of a table one, and don't worry if you can't read it. I didn't expect you would, but you know, the paper for most research studies and clinical trials, the very first table will be a table one, which looks at the patient characteristics that were studied there. Characteristics, comorbidities, et cetera. This one I've highlighted history of diabetes. Well, it's not often clear. In fact, it's rarely clear from a research publication exactly how that was operationalized. So was that determined through ICD codes and which ones and labs or medications? And that has an impact in understanding the population that was studied and whether this knowledge that's generated, these results would be applicable to your population. And so having this kind of transparency, plus the ability of standards that could more or less automate this kind of information so that it could be disseminated alongside the publication, will really move us toward being able to see and understand results. And quite similarly, I think this gives us that leg up on deploying new knowledge. So as we identify interventions, and that would include supportive tools in the EHR, decision support, care coordination tools, messaging, that type of thing. These could then be deployed more quickly and allow us to have that uptake into practice move much faster. And I just want to take that opportunity to highlight, if we start thinking of this idea of knowledge objects coming out of research studies and standards enabled knowledge objects that could be really inserted or plugged into systems more easily, this really gets at the problems or the issues that the knowledge grid and mobilizing computable biomedical knowledge are dealing with. And these are both projects that live within the Department of Learning Health Sciences. Alan Flynn leads the Knowledge Grid project, and they're looking at all kinds of technical aspects about moving these knowledge objects into practice. But again, a key part, and I think having the data in a standardized format and having receiving systems in a predictable format can really speed how we move that forward. So these are very exciting times, and lots of potential for data standards to really accelerate what we're learning there. So with that said, and I think 95% of us on the phone today said data standards are really going to improve research, or have potential to improve the speed of research and our learning and what we know. Why has this been so hard for us? Why have we just continuously been challenged to have standardized data? And again, I'm talking particularly clinical data coming from our EHR systems, because I see a tremendous value for pragmatic research in that. But standards is a very broad term, as you'll know. So I'm going to highlight 10 challenges, and then I look forward to some discussion about those in just a few minutes. So knowledge representation is difficult. This is Scott Bloys was one of the fathers of informatics. This is a wonderful book that you could check out from the National Library of Medicine electronically. He has really given a really philosophical take, a really thoughtful analysis of medical knowledge and medical concepts and how challenging they are. And sort of as a body of knowledge, it's very complex, it's changing, it's voluminous. There are multiple levels of granularity. So we need to think and talk about concepts from the chemical level to the biochemical level, to the organ level, the system level, the person level, the population level. And so we need linkages across all these different ways of looking at concepts. We certainly have lots of knowledge domains and a lot of subjectivity there, and time is very critical. So it's a challenge just to represent medical knowledge. And then information management, sort of managing this within the context of healthcare systems and visits and patients and problems. There's a lot of variety of how things can be interpreted and some challenges there. So in the top left, I've got, this is more of an ontological representation of knowledge about sort of what's the generalizable assertional knowledge that body system findings can have a body site, and that there's contextual knowledge about, well, this is a finding would be found on a physical exam. These things are medical knowledge. They perhaps don't change, or most of the time don't change. But then we need to insert those into individual records and health systems that represent individual patients and visits and notes and sections of notes, et cetera, et cetera. And so there's some challenge in that, and there's just a lot of different ways to do that. And historically, organizations have been doing that themselves. They haven't had this need to coordinate with others exactly how they represent these details. So there's challenges just there. There's also challenges in terms of knowledge representation just at the highest level. So if we're going to talk about standards in any way, the first thing we sort of do as humans is sort of bucket them and say, well, okay, what's the best standard for diagnoses? What's the best standard for problems? What about findings? What about adverse drug events, allergies? Are those really findings? You know, how do we lump them together? Medications, are we thinking about products, substances, orders, nursing, different measures, social determinants of health? There's all kinds of ways to bucket this before we start talking about what the standards are. And people tend to do it differently, and organizations do it differently. So just deciding what we're talking about can be a challenge. And historically, people have just approached it. There's a lot of commonality in how people look at things, but there are different ways to bucket this, which again just challenges us as we try and communicate it. And then most importantly, standards themselves differ. So I'll tack this at 3 different levels, and these next few slides will be visually overwhelming, but that's sort of intended. Standards development processes differ widely. So you can have ad hoc standards. The DICOM imaging standard is a great example where the radiology community and the manufacturers came together, saw a need for a standard, built it, and put it forward as the experts in that area. You can have de facto standards that nobody has said you have to use it, but people do. And you could have government mandates, which are very, very effective. So think of your ICD coding system for billing, or CPT codes. If you're MEDRA for clinical research reporting to the FDA, if you're mandated to use it, then that's one guarantor that you're going to have some adopters there. And then there's consensus standards, which are developed in there's an entire process and set of checks and balances for organizations to make sure that they go through the right process to get the right stakeholders, the right input, and move things forward in a valid way. And so these tend to take longer, but be more inclusive. So there's pros and cons to each. But when something's a standard, the first thing I always tell people to think of, well, says who and how so. So there's variation there. And the standards organizations themselves vary tremendously. Some are these formal standards development organizations, and others are coalitions, professional medical societies, and federal government. And then just quickly, this will probably be my last busy slide, just to show you the kinds of organizations that are there. And again, there's no one central person on top that's sort of master planning all of this. So in the bottom left, we have lots of government agencies, FDA, CDC, CMS, the Department of Defense, that are making standards. We have National Council on Prescription Drug Program. We've got a number of terminologies and code systems on the right, each one of them. We have HL7, which is healthcare standards. CDISC is research standards. ISO and European Standards Development Organizations are there. And there's an attempt to sort of pull them together with this Joint Initiative Council. But, you know, it's a challenge, right? And so the people are coming at this from all different angles. So there's some complexity there. And then finally, if there's not enough variety in the organizations, then the standards themselves are actually quite different. We have data elements and values. We have code systems, and a coding system could be a value set for a data element. So a data element could be as simple as ambulatory, yes or no, or it could be a diagnosis or problem and refer to an entire coding system or classification system, such as ICD-10-CM, or a certain part of, say, the SNOMED terminology. Mappings between coding systems, if all coding systems were equal, we wouldn't need mappings. They're different, right? So it depends on the purpose, it depends on the direction. You need the right expertise to develop mappings. And so the ones that you choose are very fit for purpose. And so there's standards in terms of how one crosswalks between some of these different coding systems, and survey questions and responses. And I think of all of these as really broadly data representation standards. And then there's also a set of standards revolve around the exchange or access of information. And these are more, have a higher level sort of information model associated with them. But again, the point is there really are just two very different types. So it's like apples and oranges when we're talking about standards. Just to give you a quick overview, just to show you some of the differences, I just thought I would highlight a few. This is RxNorm, which is standard for medication data maintained by the National Library of Medicine. So you'd have a code number here for a Deltazona brand name. It's got a random string code number, a 6-digit code number, but that actually represents to a very specific brand product. You also could have those same code numbers referring to ingredients, clinical drug, which would have actually combinations of ingredients plus dosage. You could have your dose form, whether it's a tablet or an oral solution. There's codes for each variation of these all the way to branded products. And this doesn't even get at the actual packaged products that, say, a pharmacy information management system might be looking at, or the classes that you might want to look at if you wanted to query antipyretics or anti-inflammatory drugs or diabetes-associated medications, for example. LOINC is a standard for labs, or really anything that can be tested, measured, or observed about a patient. So it's historically labs, and the majority of the content there is labs, but there's other aspects as well. And so each term has just put an example of a code number, a random string. Well, it's not random, but it's a signed string number. But each code has a part. It's got an analyte, and then what you're measuring, if it's a mass concentration or a serum concentration or a rate. There's a time component, point in time, 24-hour, a sample, whether it's serum, urine. So each code has this information embedded in it. And that's sort of the structure of LOINC. One quick note, for those of you who aren't familiar, I'm curious to just take a guess. We don't have a chat function, but just in terms of glucose codes, I just wanted to look up how many codes there were for glucose tests. And there are well over 800 different codes for glucose tests, because each code has that level of specificity about the sample and conditions around it, the oral glucose challenges associated with that, et cetera, et cetera. So there's a lot of detail here, and to practically get the data out or roll it up, or to make sure you're coding in the right way, this is a complexity that needs to be dealt with. Similarly, I think a lot of folks on the phone are probably familiar with ICD-10. It's maintained by the World Health Organization. It's classification. So a disease fits in any one chapter and only one chapter. And then the clinical modification version of that we use here in the US for billing, they've put some semantics within the digits. But again, fundamentally, it's still a classification. And so you've got terms that just fall under one category of diagnosis or body system typically. And then finally, SNOMED CT is got more sophistication in terms of the relationships there. And so this is hard to visualize. Perhaps this is a screenshot from a browser, SNOMED browser, but it just shows the concept of myocardial infarction here. On the left, you can see it highlighted, and below it are all specific subtypes of it. And so there's a formal relation between those. So you could search on myocardial infarction and you would pull up all these subtypes. On the right top, you could see that there's synonym names for it. So you could build your interface and collect this in any way using any one of those terms, but they will all sort of map to this common preferred term of myocardial infarction disorder. And that's in a disorder hierarchy. It's got some relationships that define it. So there's no narrative language definitions, if you will, but they're formal definitions. So there's some potential here. One final note on SNOMED It also has a model that's not used much in real systems. This is called post-coordination, where instead of having to pre-coordinate and list every possible pain and every possible body part and every side of the body or modifier, you can have this model to do that. And so things like family history fall under this, negation can fall under this. So there's a lot of ways to add context within SNOMED. And so that can prove to be challenging in many applications. And finally, as we look at all those code systems, one area of standardization, if you will, in terms of learning health systems is how can we standardize and reuse our definitions for patient populations using computable phenotype definitions that build with many of these different code systems in different pieces and different sequences and logic and things. So this is a challenge that I still see as outstanding, and another type of area where we can standardize health data and be ready to go for some of our the observational and interventional studies we want to do moving through our learning health system. So let me pause for a minute, and this will be the last. I'm going to give a quick overview of FHIR, but I wanted to hear how many people have heard of FHIR, and I want to hear to what extent. So I'll pause while you read this question. And we'll give you just another few seconds on this. We're not going to publish these results, so this is just to get a sense of how we feel about FHIR. There's a lot of hype. Host and panel. Oh, I can't vote. I saw the poll go away, so I'm assuming that we're calculating.
Yes. Would you like to know the results?
Yeah, can we show the results?
Yes,
Ooh,
absolutely.
Yeah. I just want to see how okay. This is great. So, okay, so there's a lot of hype around FHIR. So this is interesting. I wasn't sure if a lot of the audience would say, yes, I've heard of it, and it's going to change the world. That's what I thought. And it seems like just the smallest group actually knows someone that's actually developing FHIR. FHIR is a standard, but it's an HL7 standard, is fast health care. Okay, let's see if we can close this. Health interoperability resources. It is a data exchange standard, if you will. This is a way of sort of applying common web standards and API application programming interfaces and creating rules around resources. So sort of bucketing different types of health data in a very predictable way with a set of attributes that theoretically any programmer can then get at and build applications off of. And so again, this is very tiny to read, but you can certainly, what I'm showing now is available on the web. So you could go in and see what kinds of buckets of data there are. There's some starting resources around concepts and code systems and the data itself. And then we've got some base resources that are useful for nearly every program: patient, practitioner, let's see, organization, substance, device, right? And so each one of these, there's some specifications for how that type of data would be managed. And then as we move into the clinical realm, we find things that you all, I think, would find useful: allergy intolerance, adverse event, condition, procedure, observations, medications. So there's these buckets of data and specifications for how to represent those. And with each one, I'm just going to show as an example, this is the immunization resource that I thought was very timely. And so this immunization resource, actually, like all others, the immunization resources at the top, it has a number of attributes: identifier, status, recorded location, manufacturer, lot number. These are all pieces of information that can be used to describe this immunization type of data. And then there's specifications for code systems or value sets that could be used or that must be used. Some are optional. There's a lot of flexibility here to allow different programmers to build applications as they want. But with that flexibility are some challenges. So just in this case, between vaccine code and status, there's a couple of different ways we could represent status not given. One, we could put all of this in SNOMED. So along with the vaccination, we could have the situational context that I described. There is that ability to post-coordinate this and put that in with the code, or it can be split up in different attributes within this data. And so there's challenges for programmers in doing this consistently. And so I think while FHIR is very, very exciting, there's a lot of work to be done to make sure that people use it in consistent ways so that we really do get standards and interoperability that we're looking for. So I wanted to quickly move out of that technical portion. My slides will never be this busy, and I will quickly get to the end. These last few will be fun. With all that said, these are complex, right? This takes resources to maintain. Volunteers only get you so far. People have to manage the terminology, version control, requests for new terms, retiring things, licensing. There's all kinds of things. And organizations sort of end up sometimes having just, they end up needing to just feed the organization. So that's a challenge, right? So once these standards organizations, the people that work there are very committed and have put a lot of time in this. And so there's real people behind each of these organizations. With that said, there's so many standards, right? They're all designed for a specific purpose. So they're designed for a very specific clinical area, for quality improvement, perhaps, for reimbursement and public health monitoring, for adverse event reporting. So each one, are designed around that. And sometimes it's challenging to look at something and say if that fits exactly what you need without tweaking it. So the fact that they're all very purpose specific is a good thing in terms of responsiveness for that standard for that group, but in terms of reusing it, it makes it challenging. As I alluded to before, standards have to fit into complex systems. So again, with the SNOMED is a perfect example. There's multiple ways to represent the family history of something, and there's lots of ways to represent that within an EHR system or a specialty research system. You can have different data fields for the family member versus the diagnosis. You can roll that all into one code. With the LOINC codes, you can have your units as part of the LOINC code in one little bucket, or it could be split up within your information model. So there's just lots of ways to do this. And it's really important as you think about also getting the data out. There's lots of ways that clinicians can find to put data in, no matter how the system was designed. So the best example that comes to mind is the advanced directives. One of the trials that I'm working with the NIH Collaboratory is looking at advanced directives. And there's a module in EPIC for this, but that is not where people are putting them. They're finding them in text notes, references to them, et cetera. So they're really having to do a lot of work to find the data. It's not necessarily where it should be or where you think it would be. So there's a lot of variation in that. And so to solve this, we need a lot of collaboration, but we need deep technical expertise to understand the structure of the standards, the structure of electronic health record systems, and the databases beneath them. And we need clinical collaboration, not just domain expertise. We need deep domain expertise to really create and maintain some of these standards, but we also need workflow expertise, people that are actually using the system that understand the kinds of patients that they're seeing and in what context these data are entered or not entered. Clinical and research communities are quite siloed. Historically, there's been a parallel set of data collection for clinical trials and regulated research. And healthcare has been its own silo, if you will. And the research community thinks very differently about data collection. It's very structured. Case report forms are sort of the currency there. And clinical research answers is regulated in really an entirely different way. So I think enabling our health systems to do pragmatic research and build real world evidence is really going to demand that we pull these communities together. And how do we do that? Incentives are needed. We just historically haven't had them. Healthcare systems haven't had a value incentive for sharing information to this day. And they still need an incentive, I think, to really value research and work with some of these standards that are really time consuming and take work. This picture of these goats, I saw a story on 60 Minutes recently. They climb the top, there's salt deposits at the top. And these mountain goats climb up what appears to be a vertical angle here to lick the salt. And they're very motivated and they do it. So, incentives are needed to move us forward. And this will require ongoing work, collaboration, and negotiation. This takes time and money and commitment. These are not one and done. I mean, standards are ongoing and dynamic. They're changing with everything we know about medicine and how we deliver healthcare. So So that's a challenge. And I think finally, a common vision is what we need to make this happen, to really push standards forward in a way that can be usable, not just for research, but quality improvement, patient care, all these different components of our healthcare system. And so that vision could be a lot of different things, but I think one component of that is a collect once, use many idea, right? We want to minimize data collection and maximize the value and readiness of our data for research. And again, having this idea and this shared vision, which we're all working so hard together to build, about what a learning health system can be and how that can influence the world around us. So, and again, how we can move these knowledge turns forward. So as I begin to wrap up here, all those 10 challenges, big stuff. It's decades and decades of in the making. I thought data standards would be solved when my last maternity leave. I thought, or my first maternity leave. I thought, okay, I'll take some time off and we'll see if these problems get solved. But they're still going on. But what makes me very hopeful moving forward is just the change in the climate and the ecosystem. Patients have just come front and center and play such an amazing role in determining what types of research get funded and what kinds of questions we ask. So I think there's a great role that patients and consumers can play in moving standards forward. We've seen the development of the PCORI and then PCORNet and other research networks that are coming together to share data to answer big questions at a national scale. The quadruple aim has been articulated. I mean, we still want the triple aim as what we're looking for: better outcomes, lower costs, improved patient experience. But the clinician experience is important too. So we want to minimize burden on data entry and maximize the value of that data. And there's a recognition for that. We've got the Office of the National Coordinator, the International Standards Advisory, and we've got common data elements coming in a process for this. There's processes involved in getting core data elements that everyone can use and that can allow the full community to weigh in on those. So these really are standards that are developed, if not consensus standards formally, I mean, with certainly input and community consensus. HL7 fire, as I mentioned, you'll hear it more. It is everyone is excited about fire. It's got such potential to allow lots of people to build wonderful applications off of the data. But, and it's really, I've never seen a standard that's had so much momentum behind it. So there's potential there. And the idea, again, is that we can build innovation off of that and then disseminate it in a standardized way. The 21st Century Cures Act about limiting information blocking and getting information to patients and giving patients control of their data and engaging in their healthcare. And then finally, I'll just make a mention about the National Cohort, COVID Cohort Collaborative, N3C. In a very short time, with the right motivation, and COVID has proven to be the motivation, we've seen over 100 organizations pull together and share data, put it in a common repository, an enclave, very protected, but that level of cooperation is something I've never seen in research before. So there are some exciting potential there. And I think what's most exciting, and I will end on this point, I'll share a couple more slides, but I'll end on this point about this standards consult service. This is what I would love to begin to offer as part of MSHAR. We put this in our grant renewal application, but I think there's some value in having someone like me that is familiar with the breadth of organizations and different approaches and what's going on in the world in terms of standards and who might be helpful in that process to consult on different needs. So I'm not sure what types of questions that I'll get, but I would love to have a conversation with you on sort of what's the context, what are your goals, what kinds of resources and limitations do you have? I could be able to potentially suggest relevant standards or standards development organizations you might work with, collaboratives or initiatives that might be relevant to that. And we could talk through some short-term and long-term goals and activities. So there might be a quick fix or a quicker fix for your immediate problem, but maybe there's a way to think ahead about enabling future activities. And so maybe we could identify those goals and some activities that go with them, and potentially identify students or fellows that can, tackle some of these problems. I think would be a really great service and helpful on both ends. It would certainly be helpful for me to understand the kinds of issues that we're dealing with here and elsewhere in terms of research, and really build our readiness, if I can contribute to that, for different research in learning health system endeavors. And then finally, if there's interest and we identify projects, there's very unique informatics questions that I think are fundable, and there's many papers to be written on the state of standards in very particular areas and how we might move those forward and what methods work best for that. So I would be thrilled to work with people on those types of topics. In terms of evaluation criteria for standards, I'll just say, basically it's content, right? But we want to make sure that they're understandable, that the code systems and the parameters are clearly defined, that it's reproducible. We have explicit specifications, documentations on this, and a good process. Usable, are there cost concerns, intellectual property concerns, licensing, that kind of thing, and then ultimately, are they useful? And have these been validated and used other places, or is that something that we need to put into our roadmap, if you will? And then the ONC there's some more practical criteria for how mature a standard and the process around it is. And finally, I want to end on just this idea of, can we build standards roadmaps as part of our infrastructure for learning health systems here? And, do we do this by conditions, by specialty, with the goal to participate in certain networks? I think there's a lot of ways that we could approach this. And again, we would start small. How can we look at the variation of what's collected? Does a standard exist? And if not, work our way to defining the right people, the right organizations, maybe in some cases building them, but then getting them into use and disseminating the standards in the world, so that we can realize some of these visions about efficient data collection and documentation, and then the use of it for real world studies and real world evidence. So with that, I will stop, and went a little into our discussion time, but I'm curious for your reactions on any of this, and in particular the consult, and then the last half hour we can even dig more in depth for people that have very specific questions. So
wow,
Chuck,
thank you, thank you, Rachel. Thank you so much for covering so much material so clearly in such a short period of time. I think you've all given us a sense of the structure of the field of standards, and I think it can be called a field, and also laying out both the potential for all of us in our research and clinical programs to take advantage of standards, but also the challenges that lie in front of us. So thank you again, and welcome to Michigan. We need you. We have several interesting questions. We'll get through as many of them as we can before we break and go to the full and unmute everybody and go to the final, more informal part of our program today. Let me start with a question that goes to the diversity, equity, and inclusion theme that is so much on everybody's mind these days. In these processes of generating standards, who's getting left out as a matter of practice as it's currently done?
Yeah, great question, and thank you. I really think the patients are being left out, really, as the biggest group. I think there's a lot of care, especially in a lot of disease-specific areas, in terms of identifying certainly clinical measures and standard observations and things that are important on the clinical realm. But then as they move to sort of the functional kinds of measures and quality of life measures, even if they're captured in EHR and clinicians are asking these of patients, I think there's sort of the presumption that patients have been involved in them, but in the developing of these, but I don't think that's always the case. And so, the exciting part that we're seeing such movement in terms of patients being involved in research, I think largely through PCORI. So PCORI is developing and has created and sponsored and really generated such a body of knowledge about how to engage patients in their healthcare, but in their research, in terms of defining what's most important to them, what kinds of functioning, what does mobility mean to them, how would we then take that concept of what's important to a patient and translate it into measures of steps per day, or number of outings per week, or that type of thing. So I think it's exciting to see this happen more formally where patients are getting involved. And then I think by extension, different types of patients. And so how inclusive are we being in terms of getting the right types of patients, the full spectrum of patients and patients that are affected in different ways, and identifying what's important to them, which I think PCORI's done a great job of eliciting that from patients and developing methods to do that. But then why not take that one step further and understand, how would we record that in a standardized way? So that whole world of patient reported stuff, I think, is very important. But it just, well, I'll just stop there. I think that's probably the best answer.
Okay, thank you, Rachel. And another question goes to the education domain. How will graduate programs, as of now or in the future, change their curriculum to training the next workforce dedicated to resolving these challenges in data standards and learning health systems?
Yeah, that's another great question. I think as I showed, and I tried through sort of overwhelm effect in terms of the visuals, the number of standards, the type of standards. I don't think it's possible for a program to really go in depth on all of these, but I think showing some of this variety and really engaging students in the importance of standards and how to have multidisciplinary conversations, which I know is one of the things that we value in our department, but in all of these healthcare problems, they are multidisciplinary. So I think having an appreciation for standards and all that's out there, understand how to navigate that space and negotiate with folks to make the best use of what's already out there so that we're not reusing things, but to be aware that a lot of times when we're building things, it might be worth a look to see what else is out there so that we don't contribute to more variation of the way data is collected and represented in the world.
Okay, I'm trying to skip around here. We've got quite a few questions, and we'll take many of these into the next part of our session today. But here's one relating to EHRs. EHR vendors have a role to play in embedding data standards on the front end, which supports clinician data entry efforts and produces closer to research-ready data on the back end. Yet, as the cliche goes, if you've seen one EHR installation, you've seen one EHR installation. What are your thoughts on gathering even greater cooperation between vendors, researchers, and health systems?
Yeah, that's a great question, and I agree. This is so easier said than done on any of this. And on the different networks that I work on, where we've got multi-site studies, and so groups come together. It may be sickle cell disease, or it may be the dialysis community, or whatnot. Groups come together and identify important data elements, but it still takes work to get those in the systems. And just as the questioner mentioned, those systems have been customized. So there are sort of standard builds that come out through Epic, for example, which has a large market share. But so much of the data that there's so much customization that it's really hard to get things through that mechanism. But I think that's the way to go, to really lobby with electronic health record systems. But it's hard. It's about that cost benefit analysis. So I think the time to make that value argument and to really demand these standards is at the time of purchase. I think so once we've sort of purchased our systems, it's harder to get those enhancements. But I've certainly seen many communities that have come together to sort of lobby for standards and work to get that into say Epic and move that forward. But I will pause and just say, to walk away from Epic, I think there's a big role for standards development organizations here, because while it's tempting to say, well, 85% of our health systems use Epic, so let's really work our standards through there. If you don't go through the standards development process, there's still dozens of other EHR vendors that don't have that access to that, or maybe doing different things. So I think that, really the standards development organization is the way to go. But the more that we can come together as researchers, as advocates for learning health systems, as advocates for patient communities and in our community about what data is important to capture and how important standards are, I think that increases our leverage to be able to do that. So, and there's lots of folks, I know the Office of the National Coordinator as a whole task force and report on sort of enabling research and learning health system functions. So there's a lot of attention, which is exciting. It's a big lift, but I think the more we work together and define clearly requirements, that makes it easy for EHR systems to adopt, and health systems have a compelling case to want to go to that trouble to upgrade and do all those things. I think that will get us in that direction someday.
Okay, we'll make this the last question before we transition to the more open part of our session. Again, I think complementary to the questions that have been posed to you already. Much of the behavioral changes need to occur at the provider level. New ways to enter information, new coding to learn. This population is typically the most resistant to get to even online training. I'd be interested in ideas surrounding training curriculum, funding, and institutional buy-in to provide incentives at all levels of providers. And the question goes on to list different kinds of providers. What do you think?
Yeah. Good question. And I agree. I mean, the challenge to me, let me say, the way I approach this, which I think probably a lot of folks on the phone, is to think of very specific specialties, clinics, disease area, service lines, and what those workflows are and what kind of data are collected in the course of workflow. And then to think about all the potential uses of those data. So obviously, what are all the patient care aspects, the care coordination kinds of uses, the potential decision support, the population management kinds of questions that we want to ask, and sort of get engagement from that team and that specialty around what data would be most important in the clinical realm. But then if the quality measures and the quality improvement folks could sort of work together and be part of that discussion, as well as the researchers and public health people, I feel like this collect once, use many means you really need to have a broad sense of the many possible uses and have those represented. And that's a tremendous challenge. And as I approach that sort of group by group, specialty by specialty, then this coordination across specialties really becomes a challenge as well, and why we need to have people that can sort of crosswalk teams or make sure we have standard approaches or standard approaches to certain vocabularies or question banks that would put things in, common FHIR profiles as we move towards FHIR, or common approach to that across all these disease areas. So I think we really do need to focus on that initial use, that entry person, and make things usable. There's a whole field of usability around that, but I think if maybe this is naive, but I really believe that if the people that are giving the care and entering the data absolutely believe that that data is useful, not just for what they're doing day to day in their care and their patients, but improving knowledge to improve the protocols for the future, I just think we would see more diligence in this, and we'd see more buy-in, and we'd see people engaged in these discussions about what to collect, what not to collect, what's the priority, and how do we automate that as well. So a big challenge, but I agree, getting those frontline providers in and getting, back to the education point, sort of indoctrinating this as in the education, that there's this need to contribute to the field and to make things better, and data standards are a part of that. So I'll pause there.
Okay, thank you, Rachel. Okay, what you all see in front of you now is a closing slide, or something that looks like a closing slide, but we are not ending this session here. After I just run through this thank you slide and thank those of you who may need to leave at this point, I want to invite all of you to stay on for a more informal continuation of this session, where, as I said, we're going to unmute everybody, and this will become more of a group chat than a formal webinar. So let me just say, for those of you who do need to leave, thank you for attending. There's a post-event survey, which is very important, and you'll see a link for that as you exit the webinar. A link to these materials will be placed on the archive of the LHS Collaboratory website. And finally, the next LHS Collaboratory session will be next month on February 23rd. This will be a fascinating session co-hosted by the Collaboratory and our University of Michigan School of Dentistry, which, as many of you know, has within itself initiated a major learning health system initiative. And this session will be focused on digital transformation in healthcare for a diverse world, featuring Dr. Mariano, who is the Chief Information Officer of the World Health Organization. So we're very excited about this session and looking forward to collaborating with the School of Dentistry on it. Thanks to everybody who participated today, and we'll see you all at the February Collaboratory session, and there'll be plenty of publicity about that as the date gets closer. Thanks again. Thanks for coming. Have a tremendous day and rest of your week. Bye-bye.